Okay, that's it. Okay. Well, welcome back from the break. And I say that I hope your break went better than our technology seems to be going today. So let's resume talking about components contributing to pain. And we have listed them up on the slide. And some of them we've kind of touched on up to this point. But we would like to highlight that stress is an important factor that mediates pain symptoms for people in general and developmentally disabled people in particular. So that, as we might expect, a higher level of stress tends to be associated with a higher level of pain problems. How does this come about? Well, stress has some physical impacts, including release of adrenaline, and associated hyperreactivity, hyperalertness to noxious stimuli, negative events, including pain problems. And stress has psychological impacts, which include lowered resilience. So a person with a pain problem who is developmentally disabled and is now experiencing a higher level of stress is going to have some physical things happen that make pain harder to cope with, and also some psychological things that make pain harder to cope with. Another circumstance where people with developmental disability can experience increased problems with pain are circumstances in which boredom occurs. So, for example, waiting online for lunch or other kinds of situations in which there's some sort of delay, low stimulation conditions brings up the internal sensations, including chronic pain problem, brings them to the forefront of the person's attention. And the last item that we'll touch on this slide has to do with reinforcement. And you might recall from our Psych 101 classes, which we'll be repeating a whole lot of here, but who wants to do that again? Nonetheless, there are two basic types of reinforcement to think about. There's operant reinforcement and there's classical reinforcement. So what does this have to do with pain and developmentally disabled? Well, sometimes developmentally disabled people are accidentally positively reinforced in an operant way for experience of pain symptoms and expression of pain symptoms. An everyday example of this might be that when the person addresses pain problems or cries out in pain, they get more staff attention than they get at other times. So that is a reward for experiencing and expressing pain. The other type of reinforcement process, classical type, has to do with, very technical term, stimulus generalization, everyday English. Have you ever noticed when you go out to dinner at a restaurant, while you're driving to the restaurant, you might have a bit of an appetite to eat dinner, but you're not ravenously hungry. But when you sit down at the table and they hand you the menu, a lot of times your appetite increases. And that's because you have learned to associate sitting at a table in a restaurant and getting a menu with hunger and with the satiation of hunger. And similarly with pain symptoms, if a person, whether developmentally disabled or not, has a chronic pain problem, those pain symptoms tend to occur in certain circumstances, like, for example, during physical therapy or towards the end of the interval between now and the last pain med. Sometimes the circumstances of that pain can come to be associated with the pain. So the physical therapy room, or the time of the day, or thinking about the activity may come itself to be associated with increased pain sensations and complaints. So these are all components that can contribute to pain. And yet one more way to look at pain in the developmentally disabled has to do with brief symptoms versus longer-term symptoms. So many times when our developmentally disabled people that we're working with have to go for medical procedures, even diagnostic procedures, we often find that they need extra time to get through these procedures. They're going to need extra explanations. They're going to need extra empathic and supportive interactions with staff. And unfortunately, sometimes the medical personnel that are doing these evaluations or medical procedures are not sensitive to the needs of developmentally disabled people. They may not recognize signs of distress, and may not know what's expected in terms of taking extra time. So medical procedures and diagnostic appointments can be a significant source of shorter-term problems with pain for people with developmental disability. And then in the case of longer-term pain, as the slide says, there's a risk that such pain will be undetected and untreated or undertreated. You know, in general, all problems that are primarily communicated verbally or by observation of the patient are particularly likely to have delays of when they're detected and delays in getting proper treatment. Research, for example, with non-developmentally disabled patients shows that people with psychological problems, which are primarily verbally communicated, can take months or years to get proper treatment for their psychiatric difficulties. And studies of pain management in the non-developmentally disabled population, we also find that frequently there are long delays between, on the one hand, when the pain actually started, and on the other hand, when people get adequate treatment. And again, part of the reason is because we have to rely primarily on verbal communication, which is an inexact process, or observation of behavior, which also can be an inexact process. So these factors can add up in the developmentally disabled population for long delays in the adequate management of pain. Unfortunately, as we've been talking about, that can have some pretty severe consequences for the person, not only in terms of setting them up for worsening of their chronic pain problem, but also with their other medical problems and with their psychological and interactional functioning in general. Now, there are differences between people, as we all know, and certainly there are differences between developmentally disabled people, even those with the same developmental disability. And we find that everybody has different pain sensitivities. There are some people who are very, very prone to having a high threshold of pain. And other people, we have a question about gating, and I'll just get through this slide and I'll take a shot at answering it, and then the other Dr. Triggerloff can finish the process. Okay, so everybody has different pain sensitivities. There are some people who have very high pain thresholds and other people who have very low pain thresholds. Or said another way, there are some people who are very sensitive to painful events or stimuli and are going to strongly react, and other people who are not. We once had I think she was 52 years old, autistic female patient who complained of a little bit of dental pain. Oh, yeah, remember her? And we took her to the dentist, or she was taken to the dentist, and she had an abscessed tooth, and the abscess had filled up half of the available space in her skull. And you know, for most people, that would be an extraordinarily agonizing circumstance. But when you asked her how she felt, it was like, yeah, my tooth hurts a little bit, and that was it. So, you know, that's an extreme example of, shall we say, a very high pain threshold. And then there are other people who go the other way. And even within the individual, we often find that there are certain kinds of pain that a person can tolerate much more easily than other types of pain. So obviously this was a patient who tolerated dental pain very easily, but if she had a lower backache or a musculoskeletal issue, she was much more sensitive to that. And these sensitivities can change over time. So a person who was very resilient in the face of one kind of pain at one point might not be so resilient for a variety of reasons at another point. And as you would expect, psychiatric factors, psychiatric symptom flare-ups would also impact how resilient the person might be in the face of pain. So a non-depressed developmentally disabled person who has some sort of pain issue might be a bit more effective at coping with it than that same person very much free of depression. So now let's try to answer the question about gain. I'll go first. The way the pain nerves work often is that when there are different sources of pain, pain from different parts of the body, there's a neurological process by which the nervous input from one of those pain sources, and it's usually the more severe one, is, so to speak, selected by the nervous system. And that is the one that primarily gets to the brain, and then the pain in that particular location is registered. So we say sometimes that a gate is closed on the other pain nerve impulses. But if that first problem is successfully treated, then it goes up and the nerve impulses from the second, perhaps less severe area of pain, those nerve impulses now start getting to the brain and being registered. So that is my off-the-cuff partial explanation, and now the other expert, Dr. Chernoff, will finish it for me.
I have nothing to add. It's like perfect explanation. You have a bunch of neurological items standing in line, and the first one through the gate is the most prioritized one, and the gate closes, and we call that gating. And then once that issue is done, the next one in line, come on up, and so you can have several experiences the person is having that are pain generating, but the most prioritized neurological feature is going to be the one you're going to have to go with.
And I would just add that there's probably an evolutionary survival advantage in that, because if you have multiple injuries, let's say you're in some kind of desperate lethal situation, back when we were all developing thousands and millions of years ago, the most important problem might be likely to be the one that hurts the worst, and that's the one from a survival to get the initial attention until it's dealt with. That's probably how that feature of our nervous systems came to be over time.
Yep, so it's gating. But let us know if it still doesn't make sense, because we'll just keep going.
Yeah, we'll keep trying until we get it right.
So another individual variable is the awareness of pain. Awareness of any internal process predicts the pain awareness. So you might have some people who are really not too aware of what's going on with themselves, and they just don't pay attention. It's just not all that important to them. So we make jokes about people. Oh no, my left leg fell off, but I should be at work on time. So they don't really pay attention to what's going on with their internal processes, including pain. And it's also a personality feature about neuroticism and openness, and all of the canoe or ocean features that pay attention to. So the awareness of internal processes is a personality feature, but for people who have developmental disability, it also can be based on something called interoception, your internal perception of what's going on. And interoception would be like, for us, we say, I've been sneezing up here. I might be coming down with a cold. Some people are totally unaware of that until after they're dripping and getting all phlegmy all over other people. Somebody else says to them, "You have a cold?" And they say, "Well, yeah." So they have zero interoception functioning. So that awareness of the internal process is very distorted in people who have developmental disabilities. They might not be able to pick up on the cues that their body is giving them. So that might also predict their pain awareness. People who are incontinent, people who are not aware when they've dribbled some urine or they've complete urinary incontinence, and the same thing with bowel incontinence, stool incontinence. If somebody's incontinent of urine and stool and they aren't really aware of their incontinence, that also predicts for whether they're going to be able to predict their pain awareness. Spasticity, when you have a tightness or spazzing of the muscles, that's because of gating, which I'm glad you asked that question because we were able to get it in there, the spasticity might be the priority issue, and so it can mask or put outside the gate other pain issues because the body is so busy dealing with the pain that's generated from muscle spasticity. And proprioception, part of the sensory integration features that can happen with people with developmental disabilities. They're not at the top of the range, so they don't really know where their body is in space, and they don't have a real awareness of what's going on with themselves, and that can change their awareness of their pain. Another individual variable is the reactive. So they have the pain, and how do they react to it? How do they interact around the pain event? Pain in different parts of the body has different psychological meanings to different people. We had a young man who had a tremendously difficult problem with eczema on his elbows, to the point where his skin was all excoriated and it looked terrible, and he was perfectly fine with it. It didn't bother him a bit. Bothered other people because they were kind of creeped out by it, because he was flaking all over the place and it looked horrible. It was a source of infections, you know, all that raw skin. But he got almost the exact same eczematous eruption in his groin. And oh boy, even though it was a tiny little eruption and a very low level of excoriation, it was a remarkable event for him. So it was exactly the same process. As a matter of fact, it was a very low level of the exact same process, but in a different part of the body that holds different psychological meaning. So the elbow is just not as important as the groin to this guy, which kind of makes sense. Okay, resilience. People handle difficulties in different ways. How do you handle the tough stuff? How do you get over the speed bumps of life? That's resilience. So how does a recipient of services handle any difficulty? And it's going to help you to understand how they're going to handle the difficulties of pain. What's their typical level of management of a negative outcome? When they don't get their way, when they're disappointed, when they're disrupted, how do they handle that? That's going to contribute to how they handle pain. And even those who take pain in stride, they just move ahead and do it, they need competent pain management. Just because somebody is handling the pain, they have a lot of resilience, they have a lot of awareness, but they also have a high pain threshold, doesn't mean, well, I guess we don't have to pay as much attention to managing that person's pain. So we'll pay a lot of attention to that in the third module. So something that we have to pay attention to is how medications sensitize people who have developmental disabilities to pain in general. The individual will take a medication or a substance, and people with developmental disabilities are just more vulnerable to increases in the pain symptoms because of the medications or the substances that they do. There are major categories of medications that promote problems, withdrawal from any substance of abuse. And it can be a pill, it can be if somebody's injecting, they're huffing, or they're drinking, whatever they're doing, it's a substance of abuse. And there's also something we have to pay attention to in terms of changes in pain management medications. So how the medication that's supposed to help their pain is altered in some way, that can make a big difference. I'm on a roll here. Sorry. You want to go back and...
Oh, that's okay.
Yeah, I covered it.
Yeah.
Okay. More technological. Fun with technology. We're so good at this. So withdrawal from any substance at all is going to disrupt what's going on with the pain management program. So alcohol, opioids, stimulants, anti-anxiety or anxiolytic medications, and antidepressants. All of these things will sensitize people to pain. So withdrawing from any substance of abuse, it's an important consideration because the population of people who have developmental disabilities and a substance abuse problem is big, and it hasn't been acknowledged over the years. It's very recently, just in the past couple, 3 years, that we've seen a lot of publications in the literature about substance abuse with people who have developmental disabilities. They're getting drunk and high a lot, just like other groups of people are. So it's an important consideration. It's something we have to keep in mind. When you reduce or you remove the substance of abuse, it's going to have a bigger impact on somebody who has a developmental disability than it does in the general population. And you know how much it disrupts people in the general population. If you've ever had a friend or relative, or you yourself has tried to quit smoking, you know that that is not an easy thing to go through. I mean, nicotine is a tough addiction to kick anyways. But that's not even the same kind of substance of abuse that we're talking about, like with alcohol or marijuana or stimulants of some kind. So each substance of abuse has a different action on the body. For example, alcohol. Alcohol is a drug, it just happens to be liquid. And it increases the spasticity when you remove the alcohol. The alcohol kind of loosens things up a little bit, but when you remove it from somebody who's used to taking it, their spasticity goes up and their pain level goes up. There are also painful stages of withdrawal from alcohol, such as tremors. So even if the person didn't have a tremor before, now they're going to have a particular neurologically induced substance withdrawal tremor, and it hurts. Withdrawal from opioids, if people are taking pain medication, opioids in general create a sense of euphoria, but they also have pain management. So you have those two things together. When you reduce or withdraw from the opioid, you're going to have what we call rebound. You're going to rebound with the pain sensations. You're going to be in more pain than you were before you were taking the opioid. Oh, isn't that a nice surprise? But there's also an irritability and a reactivity of the neurological systems that weren't there before, because the opioid changes neural pathways, and it changes how those neural pathways are established and respond to other messages from the system. So all of a sudden, this person is going to be more irritable, they're going to be in more pain, and everybody's going to think, well, they can't come off these opioids because look what bad shape they're in. So there is a way to do it. We'll talk about that in Module 3. Withdrawing from stimulants. Stimulants give you this artificial energy and this artificial excitement, and it usually creates an emotional low that's a short-term depression. And if the stimulant happened to be cocaine or any of the versions of pain, we would call that the post-coke blues. The resilience is very low. The hopelessness rises up. The person is just feeling, they're hopeless and they're miserable and they can't handle anything, and their ability to tolerate one more thing is absolutely gone. And if one more thing is pain, they feel it totally. It's going to be very difficult for them. Then take sedatives, especially if they're taking a sedative recreationally, but even if they're taking it because it's a medical necessity, sedatives calm and soothe. They bring your anxiety level down. They try to eradicate or at least minimize your irritability. But when you come off of sedatives, your anxiety is going to go up. Your irritability is going to go up. You're not going to be able to get to sleep. So insomnia is very common when somebody withdraws from sedatives. And they get very agitated, and when somebody is agitated and they're not sleeping well and they're irritated and they're anxious, not in their pain very well. Anti-anxiety medications, or anxiolytics is another phrase for it, whether it's a planned dose reduction where there's a scheduled discontinuation, or they just need to, they have to stop using it because they can't get it anymore. It was just a substance of abuse. They were getting it from somebody's medicine cabinet or getting it from some dealer. Now they no longer have access to that substance of abuse. They're going to have withdrawal, and the withdrawal is tough, even if it's a planned dose reduction. We had somebody who was on 4 milligrams of Xanax, which is a lot, and she was on it for a good 17 years. And it was, a medically prescribed issue. It was not just a substance of abuse. And we brought her down from 4 milligrams to 3.75 milligrams, and just that 1/4 milligram change caused rebound anxiety, where anxiety went really high, rebound insomnia, couldn't get to sleep for like 3 days, crabby, and decreased problem solving. She couldn't think her way out of a paper bag, technical term. But we knew that was going to happen. So we were able to help her through that and do it at a time when she wasn't having a major issue going on. Her sister was getting married, and we didn't schedule this for that. We waited until after the sister's wedding so that she could go through those 3 days, 3 or 4 days, and sometimes it's 3 or 4 weeks of things not being good. And then we leave her alone for a couple months, and then we bring her down another 1/4 milligram. But that's when it's medically monitored. If it's just your supply runs out, you're going to go through this, and it's going to be very tough. All of the consequences of withdrawing from anxiolytics make pain symptoms worse. and makes the person less likely to be able to cope with it because they're taking the anti-anxiety medications because they didn't want to experience anxiety, whether it was medically indicated or whether it was a substance of abuse. They were not coping with their anxiety well. They were doing it externally, and you remove that external control of the anxiety, and they're just not able to cope as well. And they didn't learn anything. Anti-anxiety medications don't teach people how to deal with their anxiety. It just removes the anxiety or minimizes it. So sometimes those problems from withdrawing from an anti-anxiety medication is interpreted as something else going on, and it interferes with assessing and treating pain symptoms. Mood stabilizers from the anticonvulsant class. We have a fair number of anticonvulsants, AEDs, that are also used as mood stabilizers. Depakote, Tegretol, Lamictal, these are the kinds of anticonvulsants that also stabilize the mood. And because bipolar disorder and schizoaffective bipolar is much more common in people with developmental disabilities than the general population, they're more likely to be on a mood stabilizer from the AED class. And any compound that stabilized the mood and is now removed or reduced in some way, that means the mood is going to be destabilized. So the anticonvulsant class mood stabilizers actually have a neurological action that increases the risk of seizures. So even if the person did not have a seizure disorder before, and they were put on a mood stabilizer that happened to be an anticonvulsant, when they go off of it or it changes in any significant way, their mood is going to be destabilized and the chances of them having a seizure increase. It has to be done in a tapered way and it has to be done carefully. That usually does not cause a seizure, but the mood destabilization can definitely happen. Withdrawing from antidepressants. Some antidepressants have a pain management feature to them, if you've ever seen the commercials for Cymbalta, but also things like Paxil and Prozac, they can have a pain management feature to them. So if you decrease or change the antidepressant, that can make the pain symptoms go up. So just something to pay attention to in the long run. People don't usually abuse antidepressants. It's not usually a recreational drug.
So when we are working with a developmentally disabled person who's already taking pain medications, so we've identified that they have some kind of problem with chronic pain perhaps, frequently we come to an event where there are changes in pain management medications. These can be schedule changes. For example, before the medication was administered every 4 hours, now it's administered every 6 hours. There can be changes in the dose. There can be a change from one type of pain medication to another type of pain medication. And there can be simultaneously changes in other medications that the patient is taking. So this circumstance where a number of changes are made in the patient's pain and non-pain medications simultaneously can pose a specific kind of problem. For example, we had a 58-year-old female autistic patient who had a history of depression and chronic pain. So she was taking Lexapro for the depression and Lyrica for the chronic pain. And she was doing pretty well. Her mood was good, and she was not complaining of pain very much. And so, of course, you can guess what happened. The dose of the Lexapro was lowered, and the dose of the Lyrica was lowered. This was done at the same time. So shortly thereafter, the patient started getting upset about increased pain symptoms. Now the question can be posed, did she have increased pain symptoms and that worsened her mood? Or did she have a worsened mood because of the lowering of the Lexapro dose and that predisposed her to increased pain symptoms? Or were both things going on, kind of a vicious spiral? And when we have simultaneous changes in medications or medication schedules, it becomes rather difficult to figure out which of those might be correct. In the case of this particular patient, we had everything going on. She was more depressed and she was more prone to pain symptoms. But if possible, if it's medically feasible, these kinds of changes should be made one at a time, so that then if we see a change in how well the patient is doing vis-a-vis pain or any other area of functioning, we have a better chance of knowing what to attribute it to. And if it's medically feasible, thinking about pain medications again, the most effective way to administer pain medications is on a regular schedule. This gives the person time to accommodate to the medication physiologically, and it gives them the opportunity psychologically to have some regularity in the pain treatment that they're getting. So a regular schedule is preferable to a PRN or an irregular schedule. And when there is a shift in the schedule, or when the schedule becomes irregular, it can disrupt the response to that medication. And so any changes in pain medications, we have to try to remember with our developmentally disabled people that it could take them a while to adjust to that change. So earlier today, we were kind of hinting at the idea that even though we're giving pain medications to help the person with pain symptoms, that sometimes what we do with pain medications can actually have the potential to make the pain symptoms worse. One of those things is using pain medication on a PRN schedule. And that can, unfortunately, work directly to increase pain complaints. So the PRN schedule is one in which the patient asks for the pain medication or reports that he or she is in more pain, and then they get the medication. So if we look at this behaviorally, we can see that the complaining of pain or the acting as though in pain is immediately followed by a positive reinforcer, which is getting the pain medication and experiencing a reduction of pain. What happens to activities that are positively reinforced? They tend to increase in frequency and intensity. So when we use a PRN schedule, pain medication often will generate an increased frequency of pain complaints, increased problems with pain, and a worsening of the pain problem. So like lots of other behaviors, we have to think about pain complaints as a behavioral process that can be made worse if we reinforce it in a certain way. So PRN scheduled pain meds can directly increase pain problems and pain complaints. Now there's an indirect way that PRN pain meds can increase pain complaints, because the series of things that happen when the patient asks for and gets pain medications on a PRN schedule also includes social interaction, and that can be reinforcing to the patient if at other points they get very little social. We are called in for patients, whether developmentally disabled or otherwise, who are having problems. And when we take a look at what's going on with that patient's daily routine, we see that the primary time that they get attention is when they complain. And when they're doing well, they don't tend to get nearly as much interaction. And that's not saying anything critical about staff. I mean, we all, as staff doing this kind of work, we tend to focus on who's having the problem. But when we focus on who's having the problem, we do that beyond a certain point, we give a message to those who are not having problems, which is that the next time they want attention, they'd better have a problem. So when developmentally disabled people have a chronic pain syndrome, one of the things that can be important to do is try to equalize the amount of attention they get, so that when they're not making complaints, they get something like an equivalent amount of attention as when they are making pain complaints. And you remember we talked about two types of reinforcement, and we said one was operant, and that's what we've just been talking about now, operant reinforcement pain complaints. But there also is classical reinforcement. So even when we have somebody on a regular pain medication schedule, let's say 10 o'clock, 2 o'clock, 6 o'clock, and perhaps they get the pain medication in a certain location, gets to be about 1/4 to 10 or 10 to 10 in that location. They're waiting for their pain meds, and we can expect that there's some risk that pain complaints may start to increase. Just like we get hungrier when we sit down at the table in the restaurant and they hand us the menu. And that's a certain kind of associational conditioning process. And sometimes we can intervene with that by providing distracting activities or trying to make different things going on, location or interactions during medication administration to the extent possible, to kind of break that effect up a bit. And I think the next one is yours.
Changes in the type of pain management medications will also need to be addressed. When you switch from one type of pain medication to another, that means you're basically using different neural pathways in the brain. You are trying to decrease the sensitivity of certain receptors, or you're increasing the sensitivity to the calming impact of some medication. So certain receptors absorb the calming and certain other receptors need to be blocked in some way. So if you switch from one pain medication to another pain medication, it might take a while for that individual to feel the benefit of the switch. You're doing the switch for a good reason. Well, sometimes it's not a good reason. Sometimes it's just not covered anymore by their Medicare Part D, and so you have to switch Medicaid Part D. So you have to switch so that they don't have to pay $324 a month for the medication. But most of the time it's for a good physiologic reason, that their one receptor pathway has been overly used and it's just not as effective anymore, and so you have to use a different neural pathway, some different receptor interaction to change what's going on with their pain sensations. But it could take a while. It might need to build up to a certain blood level, or it might need to be made aware in the body and in the brain that there's something different going on. And in the meantime, the person's going to have to. We're going to be talking a great deal about non-pharmacological interventions for pain management, because this is a pretty routine problem where there's a change or a shift in the pain management medications, and the person's going to have to be able to cope. Combining medications can be a very delicate process. A lot of people are very expert at this. They are very, very good at juggling the different medications and getting it into that person's system in a way that really works for them. But just keep in mind that a change in one medication can influence the effectiveness of any pain medication that's being used. So the person might have a respiratory infection and they put them on erythromycin, and all of a sudden everything else is just not working as well. The person's in more pain. And you think, well, look, they've got pneumonia, bacterial pneumonia, and that's why they're on erythromycin, and that's why they're in pain. But it also could be that the erythromycin is throwing all of their pain medication off, and that it's not working as well. There also can be changes in food and fluids that can create the same pain symptoms. Everything is different when things are different.
So there are, as you can see from everything we've reviewed today so far, different varieties of chronic pain syndromes. And we've talked about a lot of different contributing factors, and we've talked about the fact that chronic pain syndromes can be very complicated, both in the developmentally disabled and in other people as well. And there are two frequent, let's say, pathways that these kinds of problems are manifested. So to try to talk about that a little bit, we'll say that chronic pain syndromes are often the result of some interaction of factors to do with pain, which can include the underlying medical condition, a worsening of that condition, worsening of the function of pain nerves, psychological factors, including emotional functioning, cognitive functioning, personality problems and personality factors, and behavioral issues, which have to do with what kind of reinforcement is the developmentally disabled person with a pain problem getting in their routine or usual environment. And although there are a variety of ways that these factors can combine to produce pain problems, often we get one of these two. And the first one is pain affects the person's psychological state and behavior. So, for example, a developmentally disabled person develops a problem with chronic pain or worsens their problem with chronic pain, and then we see a deterioration in their functioning in the psychological sphere and behavior, like an increasing depression or withdrawal or agitation. And so coming at this from the other direction, when we see that a developmentally disabled person's function is deteriorating, one question that we need to ask is, could this be due to the onset or worsening of a pain problem? And then use our MESIP acronym to start looking for possible sources of a pain problem if we think one is there. The other frequent variety of chronic pain syndrome that occurs is that the person develops some psychological distress or some problem with behavior, and then this goes on to increase the experience or expression of pain symptoms. So one example is that a developmentally disabled person who is lonely or possibly depressed and maybe getting a PRN schedule of pain meds starts to complain of pain and ask for the medication more because they get some emotional support and empathy from the interaction with the staff. Another example is going back to the personality trait issues that we were discussing before, on somebody who is a somatizer, a developmentally disabled person who tends to convert psychological distress into physical and pain symptoms, becomes psychologically distressed by something or other. Maybe they're having an adjustment disorder, they went to a new facility, they don't like this or that staff person who was just hired, and they may be a little bit, remember the technical term alexithymic, so they don't usually talk about emotional distress. A person in that circumstance might begin to complain about more pain symptoms. So when we see more pain complaints, we have to look underneath those pain complaints and examine whether some psychological factor or psychological distress might be contributing. So let's take a look at some specific emotional or psychological and behavior patterns and problems and their relationship to pain. So we've kind of hinted at this first topic, pain and depression. We know that people in pain are more prone to being depressed. And we even talked about the fact that if you take two groups of people, whether they're developmentally disabled or not, one of them is depressed and one of them is not depressed. You give them all the same flu shot, the ones that are depressed are going to report more pain from the flu shot. So we know that there's a relationship between pain and depression. And one of the possible pathways for this relationship might have to do with positive reinforcement. Because what happens when a person is depressed? They don't enjoy things as much. They don't get as much positive reinforcement. What happens when a person is in pain? They don't enjoy things as much. They don't get as much positive reinforcement. So there are theories of depression that relate to loss of positive reinforcement. And pain seems to be a process that in part involves loss of positive reinforcement. So in that commonality might be part of the mechanism that explains why pain and depression tend to be kind of locked together. The more depression, the more vulnerability to pain. The more pain, the more vulnerability to depression. And, you know, if we're treating somebody, for example, for depression, we're giving them an antidepressant medication, and getting, you know, some sort of psychotherapeutic intervention, and we allow them to not get adequately treated their pain problems. Not only are we permitting needless suffering, but we're also then doing something which might exacerbate their depression and work against the treatment for depression that we're giving them. So the close relationship between pain symptoms and depression needs to be kept in mind whenever we're working with a developmentally disabled person who on the one hand has a pain problem and or on the other hand has a problem with depression. Sometimes we're called in as consultants for developmentally disabled people when there's a problem with agitation. The person is apparently agitated, they can't sit still, they can't relax, they're interacting in kind of a accelerated, sometimes a problematic way. And it can happen that that can look like a psychiatric problem because there certainly are psychiatric conditions that lead to increased agitation. For example, an agitated depression, or for example, worsening psychotic process, or worsening symptoms of schizophrenia, or if we think about bipolar disorder, the development of mania can look like produced agitation. But it also happens that developmentally disabled people, when they are in more pain, become more agitated, as might anyone else being in significant pain. Agitation is a risk. But the developmentally disabled person may not be able as easily to communicate that they are in pain. And so the restlessness or the discomfort coming from the pain problem can look like psychiatric agitation. And sometimes those people can end up being prescribed medications to reduce agitation, like an anxiolytic, like Ativan, or even, heaven forbid, a major tranquilizer, when in fact what was going on was the occurrence or worsening of a pain problem. So when we have a developmentally disabled person that we're working with and they start manifesting increased agitation, one of the possible sources is the onset or worsening of a pain problem. And if we follow the MESIP acronym, we should be able to pick that up when we look at what's going on medically, and when we look at what's going on psychiatrically. So an advertisement for the MESIP acronym, but also we would like not to give developmentally disabled people medications that are psychiatric in nature for agitation, when in fact we need to be helping them with pain problems. So often, developmentally disabled people have had to work very diligently learning some social skills or improving their social skills to be effective in social interaction. When they're in pain, the pain is going to impair cognitive functioning in general, and social skills that the person has worked very hard to learn, like smiling appropriately, making appropriate eye contact, using appropriate voice volume, understanding that a social interaction is sharing, you know, I say something, you say something, I say something, you say something.
Just like this.
Exactly. That can be a much more difficult set of skills to retain when their psychological resources are being drained by pain, so that if we're working with a developmentally disabled person and we see that they are socially withdrawing, one of the possible explanations we need to think about is that they are experiencing the onset or worsening of a pain problem. Pain has an impact on cognitive functioning, and this is because cognitive functioning requires cognitive work. Some of the work of cognitive functioning is orienting, where we notice that there's something that we have to pay attention to, and we're able to direct our attention to paying attention to it. And maintaining task persistence, where we learn to keep paying attention until the task is adequately finished. Cognitive functioning includes being able to master or comprehend or learn new skills and retaining what we've already learned. So all of this requires work, and the ability to do that cognitive work is impaired by the experience of pain. Often, developmentally disabled people have had to work very hard to master these kinds of skills, and it has not been easy for them to do so. And they are easily disruptible, and certainly chronic pain symptoms will easily disrupt those skills. In addition, pain often induces a biochemical as well as a behavioral fight or flight response. So this is something that everybody has within them, whether developmentally disabled or not. If we have enough pain, we have increased adrenaline, and we get ready to fight with the source of the pain or run away from it. So as the adrenaline floods the system, you can imagine that the ability to do the psychological work of attending to cognitive tasks and maintaining performance is reduced. So pain, it definitely has an important impact on cognitive functioning in the developmentally disabled. And particularly, you know, when we're working with the cognitively impaired people, or people who are struggling to cope with an impairment to begin with, they certainly don't need any additional drag on their cognitive function. And we know that pain affects occupational functioning in the developmentally disabled. Certainly there's a reduction in physical capacity to do the tasks. In particular, if there's pain experienced on range of motion, on degree of physical work, the developmentally disabled person, like anyone else, is not going to want to do those things. In addition to which, the developmentally disabled person may have had to work very hard to learn how to interact appropriately in the workplace with customers, with supervisors, and with co-workers. And the motivation to continue to do that hard work may be an important factor in the person's continuing to be able to function adequately in the workplace. If they experience regular pain in the workplace, the overall level of positive reinforcement is going to be decreased. Their motivation to continue to function adequately in the workplace may decrease. Their performance in the workplace may then start to go downhill. And then this can produce problems with supervisors, co-workers, and customers, leading to a general downward spiral in occupational functioning. So when we're working with developmentally disabled people who are easily impaired by chronic pain problems.
So as we mentioned before, and this is a theme that's running through the entire concept about pain, is what is it doing to the day-to-day existence of people who have developmental disabilities? The activities that we live in are not a given. They're not an assumption that is always in place. So pain can interfere with range teeth or putting on clothes. Certain clothing items might require some dexterity, buttons and zippers. So if pain is interfering with that and you have ineffective ADLs as a result, you might have somebody who's not showering very well because maybe the water hitting their skin is very painful, so they're avoiding those kinds of experiences, or they're not using deodorant, or they're not brushing their teeth well, and so they start to smell, they start to have some unpleasant presence in what's going on, and that's going to get negative reactions from people in general. So on top of getting some negative stuff coming from their body, they're now getting negative stuff from outside their body. And the pain can reduce the ability to perform the ADLs, but also it prevents negative aspects to everybody else in their environment. Their family members, their supervisors, their co-workers, their customers if they have a job, but also if they live in a residence, who else is living there? If they're living with their family, who else is in the house? If they're not doing their ADLs well, it can disrupt a very delicate set of relationships easily, and it can make it more difficult for them to maintain those relationships. So in general, what this entire program is that we're focusing on with pain is in improving the care we give people with developmental disabilities. And training is how we do it. Multidisciplinary training facilitates those effective approaches. So we're going to talk about assessment, Module 2, and we're going to talk about interventions and outcome determinations in Module 3 for pain management. And in general, the entire thrust of what we're doing is to improve the quality of life of those who have a developmental disability. And we left this time open for both going over the pre- and post-test questions. We wanted to make sure you had them so you could cheat. That's not a cheat. It's an advantage. We're giving you an advantage.
Actually, the questions will pop up on your screen as a poll. There will be poll questions.
Oh.
So you can just go through and just check off the answers. If you don't get a chance to check them off, that's fine. Don't worry about it. We just want to, get a good idea of, if you've got the grasp of all this. So we'll start with the first question.
That was Lisa. You didn't see her. She doesn't like to be on camera, but that's who she is. One of these days we're going to flip the camera around and you're going to see Lisa. and all of her beauty. Let's see. I'll do question 1. Pain which occurs in the absence of objective medical findings is called nociceptive, neuropathic, functional, or affective pain. And, you know, we went over all of these different components, but the presence of pain that doesn't have any objective finding associated with it is functional pain. We have to wait. Everybody has to vote. Or make a comment, or tell a joke, or leave the room. And then we'll do question 2. There are 5 questions.
We have now declared the election in Ohio decided.
Ohio, round in the round. Okay.
Yeah. Are we ready for the next one?
Yes.
Okay. Question 2, personality traits. Number 1, can influence a person's pain perceptions. Number 2, have no influence on a person's pain perceptions. Number 3, are the most important influence on a person's pain perceptions. Number 4, are one of the many possible factors influencing a person's pain perceptions. So, enter your responses while I indirectly hint at the right one. We know that they can influence a person's pain perceptions. And we know that there are hundreds of factors that we've gone over, so the correct answer is 1 and 4, which is C. Curtain number 3.
A person with developmental disabilities withdrawing from opiates may experience increased pain symptoms because of withdrawal-induced hyperreactivity of the nervous system, withdrawal-induced rebound pain, withdrawal-induced personality change, withdrawal-induced negative reinforcement. Four, 2 and 3, 2 and 4. I'm going to give you a second to load in on that. But in the meantime, I'm going to give you a hint. We talked about how when you are taking a medication for pain, that changes the neural pathways and it changes the receptivity of certain pain receptors and certain endorphin receptors that you're going to have in your body. So you're going to have a hyperreactivity. And I think there's only one choice that has the word hyperreactivity in there, so that's hint number 1. And then we talked about how when you take away something, you will have a bouncing up of the problem that you were trying to treat. So we call that rebound. So the answer is A, which indicates the first and second choices. So withdrawal-induced hyperreactivity of the nervous system and withdrawal-induced rebound pain. If you want us to stop singing, you will load it. Stop. Classical conditioning.
Ready for the next one?
Yeah.
Question 4. Understanding the biomechanics of pain in developmentally disabled service recipients improves treatment outcomes because, number 1, it reduces risks that recipients will be treated with opiate analgesics. Number 2, it reduces risks that recipients will be undertreated for pain symptoms. Number 3, it clarifies the uselessness of non-pharmacologic pain treatment interventions with developmentally disabled recipients. Or number 4, it emphasizes the need for both pharmacologic and non-pharmacologic pain treatment alternative interventions. So it seems doubtful that we could across the board rule out opiate analgesics for pain problems. So that gets rid of number 1. And it seems doubtful that non-pharmacological pain treatment interventions would be useless. So that gets rid of number 3. So we're left with numbers 2 and 4, and that's answer B. The correct answer is B, number 2 and number 4.
And I'll do question 5. Which of the following statements is true about the relationship between chronic pain and psychological disorders? Psychological disorders never exacerbate chronic pain. Where have you heard that? Chronic pain never exacerbates psychological disorders. There is an inverse relationship between chronic pain and psychological disorders. There can be an interactive relationship between chronic pain and psychological disorders. And as the fabulous Dr. Triggerboff has explained in a couple of different ways, we are these complex beings and there are interactions, and in general, never is not a good phrase to use. But there is an interactive relationship between chronic pain and psychological disorders. You're not going to be in as good psychological shape when you're hurting really badly. So the correct answer is D, which is number 4.
Yeah, I would just add that if you hear never or always as part of an answer, pretty much guaranteed wrong. Inverse relationship, some statistician came up with that.
Yeah, that was me. So those are our pre and post test or poll questions. I'm having to adjust my things here. And if anybody has any questions, nobody has any questions, do we have, words